Relation-based care enables clinicians to develop strong and trusting personal relationships with their patients. These relationships are particularly important when working with ethnically and culturally diverse populations. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hedderly, Senior Writer with AHA. In this Members in Action podcast, Julia Resnick, Senior Program Manager at AHA, is speaking with Casey Cooper, CEO, Dr. Rick Bunio, Executive Clinical Director of Cherokee Indian Hospital, and Principal Chief Richard Sneed of the Eastern Band of Cherokee Indians. They're discussing the impact of the hospital's relationship-based integrated care model and how it's enabled their community to better address the COVID-19 pandemic. And now to Julia.
Today's podcast is part of the Value Initiative's Members in Action series. We are highlighting how hospitals are improving value and affordability for their patients and communities. These hospitals have implemented strategies that improve outcomes, enhance the patient experience, and lower cost. Today, I'm excited to be speaking with three leaders from Cherokee, North Carolina. From Cherokee Indian Hospital, we have their CEO, Casey Cooper, and Dr. Richard Bunio, Executive Clinical Director. They are joined by Principal Chief Richard Sneed of the Eastern Band of the Cherokee Indians. We will be discussing the relationship-based integrated care model at Cherokee Indian Hospital, as well as how their community has successfully responded to the COVID-19 pandemic. I'm so glad that the three of you are able to join me today, so let's jump right in. I think that to start, it would be helpful to have some background on Cherokee Indian Hospital. So, Casey, can you tell us about your hospital? And Chief Sneed, can you share a bit about the community that you serve?
Sure, Julia. First of all, thank you for doing this, and thank you for having us on the podcast. The Cherokee Indian Hospital, in some ways, it's very similar to just a typical small rural hospital, but in some ways, it's very different. It's a tribal facility that is managed by the Eastern Band of the Cherokee Indians through its Cherokee Indian Hospital Authority. And the hospital has been under the management of the Cherokee Indian Hospital Authority since roughly 2002 under a Public Law 93-638 self-determination agreement. So essentially, we've contracted it from the government, and the service was historically provided by the Indian Health Service, but since 2002, the management has been provided by the tribe to the hospital authority. It's, again, a small rural hospital with about 650 employees, somewhere around $87 million a year budget. And the thing that makes it unique is it's a pretty comprehensive health system, unlike most critical access hospitals or rural hospitals, with the bulk of the service actually being primary care and a very expansive continuum of behavioral health and substance abuse services. Also included in some things that would not be in a critical access or a rural hospital would be things like dental services, a very large clinical pharmacy, an outpatient pharmacy program, and a number of other things. That's a little bit about the hospital. Other than that, the only other thing I'd add is that we serve about somewhere between 12,500 and 13,000 beneficiaries that are identified as American Indian or Alaska Native.
I guess I'll jump in. So again, Julia, thank you for hosting us today. It's an honor to be here and to talk to you a little bit about the Eastern Band Cherokee Indians and what we're doing, what I believe is probably the leading healthcare system in Indian country, and very proud of the work that Casey and his team do, and Dr. Bunio. Just some background on the Eastern Band of Cherokee Indians. We are the descendants of those Cherokees who resisted removal when the Indian Removal Act was signed into law by President Andrew Jackson. In 1838, our ancestors were those who said, no, we're not leaving. And they fled and they hid in the mountains. Our sister tribes are Cherokee Nation in Oklahoma and the United Keetoowah Band of Cherokee in Oklahoma. We have approximately 16,000 tribal citizens. I'm moving away from using the terminology tribal members. That is, to me, more of a governmental moniker that was placed on us. We are citizens of a sovereign nation. I think it's important for people to recognize that we are a nation within a nation, and we do have the ability to exercise that sovereignty. And one of the ways that we've done that is taking on the responsibility for our own healthcare through doing a 638 contract. And prior to that, as Casey mentioned, the Indian Health Service did manage and operate our local hospital. The difference in care that was provided then versus what is provided now is really night and day. And so I think Casey and his team, our hospital governing board, has done an outstanding job and continue to do an outstanding job, especially in the area of substance abuse. When we look at the opioid epidemic and heroin epidemic that is rampant across this nation, we have done an outstanding job of both working in concert, the hospital administration and tribal government, to see the need and meet the need of our people, both on the their physical well-being, but I think equally as important, the mental health aspect, which, as I'm sure you're very aware, funding for mental health just gets cut continuously at the state level, and there's dual diagnosis. The majority of people who are addicted also have mental health issues that are either undiagnosed or diagnosed and untreated. So we've done an outstanding job here to create a continuum of care that is very holistic and meets the need of our people.
Wonderful. So thanks for that background. So Casey and Dr. Bunio, I understand that your hospital recently did some care redesign using a relationship-based integrated care model that improves patient engagement and has had an impact on how you've been managing chronic disease. Can you tell us more about that approach?
Sure. I'll kick it off at kind of maybe a high-level discussion about the approach, and I'll have Dr. Bunio help me out with more of the details and that kind of thing. But the way it started, we began this journey to have more relationship-based integrated care. We started the journey back in 2010. After we took over the hospital, there were some immediate challenges. In 2003 through 2005, our immediate priority was try to figure out how to stop running out of cash. We were burning through our cash so fast, so we had to focus on our revenue cycle management. We had to focus on a lot of the back office stuff. And then 2005 through 2007, we started working on access and improving customer service. But it wasn't until 2010 that we had kind of corrected the ship. Things were running pretty good. We had good management and good controls in place. And so then we had the luxury, if you will, to start really focusing on population health. And as we went through a number of iterations of our core purpose and our guiding principles and our mission and vision, it really became crystal clear to us that once we had mitigated the crisis, the financial crisis, we had righted the ship and we had support from the tribe, we started really reflecting on our core purpose, which is to ensure the prosperity of the next 7 generations. So it became very clear to us that in order to improve the health of our population, we had to have greater patient and family engagement into their own health care. And we believe that their engagement is a function of the relationship that they have with an influential primary care team. And so we began this search. We were studying the Institute for Patient Family-Centered Care. We were studying a number of other different models. And in our search, we found South Central Foundation out of Anchorage, Alaska, had designed the NUCA system of care. And essentially, they had operationalized, if you will, the very things that we intuitively knew that we needed. And we knew that we needed these because we had had numerous focus group meetings. We had met with our clients and we had met with client families, and we had said to them over and over again, what is quality to you? What is good quality and what is bad quality? And consistently, our clients and families would say to us, well, I get really good care at the Cherokee Hospital, unlike other people. And we would say, well, why do you get good care? And they'd say, well, because Dr. Bunio is my doctor and he knows me. And Dr. Bunio's nurse is April and I can call April. And if I need something, I just call her directly. And my pharmacist is Chris. And anytime I have a question about my meds, I call Chris. And we kept hearing this recurring theme over and over again, that the patients who had an intimate relationship with their provider, their nurse case manager, their clinical pharmacist, and other resources, they had a perception of very high quality care, and they tended to be more engaged in their own healthcare journey. And so we knew this concept was out there. We just hadn't really figured out how to operationalize it. So when we went to South Central Foundation and we saw an entire organization that had redesigned the systems and processes to be relationship-based, and the system actually puts the relationship between the patient and their primary care team as paramount to everything. And all the other systems and structures support that relationship. And they added to all those systems and processes an entire culture that's based on empathy and compassion. And when they put the systems and processes and the culture together, the magic really started happening. And so we studied that, and we came home and we tore down walls. We literally built microsystems within our primary care clinics, and we asked teams of really highly engaged early adopters to try it. And we saw that it was working, so we tore down more walls. We got rid of more offices. We built more integrated care team space, and we continued to scale it until ultimately it was time to build our new facility. And I tell people, when that happened, we said, we're burning the ships. We're never going back. And we designed our brand new 150,000 square foot facility around this model, and then turned our attention to the culture and the corporate training. So that's kind of how we got there. I mean, that's kind of what it's about with relationship-based integrated care. At its heart, the integrated care is a nuclear team of a primary care provider. The primary care provider has a dedicated support staff in the form of a certified medical assistant or an LPN. And then every team also has a registered nurse case manager, and the registered nurse case manager has a case management support. So that's the 4-member nuclear team. And then each 3 of those teams shares an embedded master's level behavioral health therapist, an embedded clinical pharmacist, and an embedded registered dietitian, so that the team can basically become whatever the patient needs on that given day or at that time. That's kind of how we got to where we are, and that's why we redesigned the systems the way we did. And I'll defer to Dr. Bunio to tell you about its effectiveness.
So thank you, Casey, and Julia, again, thank you for having me. I think one of the things that we're seeing here is that it's been an incredible journey. And in order for this to be successful, you need an extremely passionate CEO and a supportive tribal leadership. And that this community also has been so supportive to the health system here. So when I hear relationship-based care, when you hear that, this is not something that we invented. Every small town family doctor that's been there for 50 years has built relationships. But I've been here for about 20 years. And, when we look back at where we were, there was variability. There were some that just got it. They just did it, and they would go, well, my doctor is great, but, maybe the others not so much. So when we started down this journey to operationalize this and make it the norm and move from, if you will, institutional kind of care where patients are moving through the system and might see a different provider every day, to we want you to have a medical home and a relationship with not just your provider, but the team, because in many cases, my nurse is much more influential than I can be. And so we moved into that model. And as Casey said, we burned the ships. We didn't give the doctors offices anymore that they could go into. That was a little bit of a paradigm shift. As we built this, what we found was when you build a system like this, you recruit people that are going to thrive in it. You recruit providers and nurses who believe in this. And we had a saying when I was in residency is you get the practice you deserve. So if you are someone who believes in relationship-based care, you're going to seek out a place like Cherokee, and that's where you're going to work, and that's where you're going to thrive. It's all about sort of building a system and attracting good people. The community has been really supportive. The new part of this for me is the integration, what Casey just described. I have never had so much support right there where I could get my patient to have all these, support services, behavioral health, nutrition, pharmacy. I've never experienced that. And it's just a joy to work here. And I think it's good for the soul of the providers and the healthcare staff here to be privileged to work in this kind of system.
That's really wonderful. And Casey, you've talked about the importance of cultivating culture. Can any of you talk a bit about how you've taken the community's culture into account when designing the care model, and how you've engaged the community and tribal leadership in the process?
So one of the simplest things I would say to you about culture is we have 4 guiding principles here. The first guiding principle is Uwasha Udantethla. Uwasha Udantethla. And it means to give from your heart. And it's a phrase that the elders and the speakers use when someone is in service. And while they're in service, you can tell that it genuinely comes from deep inside them. It comes from their heart and from their spirit. And so we teach that. We have corporate-wide training where we teach people the importance of Uwashan Udantethla, because many of us have had service, right? We know what it feels like when somebody does something for us, and we know that it genuinely comes from a place of caring. And we've also had service when we felt like the person was doing it out of obligation, but they weren't really doing it for us. And we knew that in order to be influential, our patients have to perceive that our genuine interest is them. It's their best interest. It's their prosperity. The second guiding principle that we have is Nihi Tzatzeli. And Nihi Tzatzeli means it belongs to you. In the context that we're using it in, what we're saying to our community is that everything here, all of the healthcare resources here, from the staff, the services, the medicine, and the buildings, it's yours. It's already yours because American Indians and Alaska Natives in this country have the first pre-purchase health plan in this country, right? So we are simply stewards of their inheritance, and it belongs to them, and it's our job to give it to them when and how they want it. Another of our guiding principles is Digwadzeli Iyonsti. So Digwadzeli Iyonsti means to be like my family. It means that he or she, they're like a member of my own family. And what we're trying to get people to understand and feel when we teach this, we want them to feel intrinsically inside the intimacy of a relationship that you would have in a healthy family, where the relationship is founded on empathy and compassion, but it's also a relationship that has influence. And we believe that in order to help our patients on their own healthcare journey, to help them work through perhaps the intergenerational grief and trauma that has manifested itself in chronic disease, we have to help them to be engaged. And we don't think that we can get them to be engaged unless they feel safe and in a relationship that's like family. And then another guiding principle is this concept of tohi. And tohi is a phrase that's used to describe when things are in balance. So Cherokee people might use tohi to describe the environment when there hasn't been too much rain or too much drought. The rivers are in balance. The greenery's in balance. Things are right. We also use tohi to describe relationships when they're healthy, when they're in balance. And what we want our employees and members of our team to understand is that we don't want to perpetuate a paternalistic power differential that has historically been in place in healthcare. We want that relationship to be based on mutuality, where the relationship could be described as feeling in tohi. So those are the four guiding principles that were developed years ago in collaboration with a group of elders from the community that were helping us as we began this journey to build greater influence in the community.
Yeah, if I can jump in on some of the points Casey made there, when we think about, and I love the fact that you use the word paternalistic, because it's not just something that you find in a healthcare system, but essentially what was imposed upon tribal nations a very long time ago. And the Cherokees were no different. And in fact, I often cite, when I talk about our history, the Cherokee v. Georgia Supreme Court case where Chief Justice John Marshall actually used that language and said, that our ancestors were like little children, that they were like wards of the state, which always made me angry whenever I read that, because I'm like, that is not who we were, and it's certainly not who we are. But the point, how all of that manifests itself in the mental health and behavioral health and physical health and well-being of our people, when I think back to when Indian Health Service ran the hospital, it was very institutionalized, a very sterile environment, a very cold environment, and that's not what you experience now when you come to our hospital. And it is this holistic approach, and having the care teams where we're dealing with the whole person. But one of the things that I think is really important about what Casey and his team does at the hospital is the training that he mentioned, that all of the staff, and I participated in the right way training early on, recognizing that in order for the caregivers to be able to give this level of compassionate care, they first have to deal with their trauma and their issues that we all have. And so it's a little bit of a scary kind of journey, because you spend 3 days or so in this training, and then at whatever level you're comfortable with sharing your story and the trauma and the issues that you've dealt with in your life. I was a vocational instructor before this, and I was always very much about sharing stories with my students and having them share stories about themselves, because once you know somebody's story, you can never look at them with your preconceived, prejudgmental notions that we all have, right? But once you hear their story, you can never look at them the same again. You see them as a strong human being, a powerful, because of the things they've been through and they've struggled through and they've suffered and they've triumphed. Or maybe they're still suffering, and then you can see them with eyes of compassion. So that model that is being developed at the hospital, and I always tell people it's like moving the needle. It's a really slow process. I'd love it if we get to snap our fingers and have that sort of growth and that sort of healing that I see happening amongst hospital staff and the patients who are being affected by it. It would be nice if we could just flip a switch and have that permeate throughout our tribe very quickly. But it didn't happen overnight to get us that way, and the healing process is going to take time as well. But it's in place, and it's being modeled, and it's being experienced on a daily basis through our healthcare system.
That's really wonderful to hear. And I think those 4 principles are ones that all of our health systems should think about how to implement in their cultures, because they're just really universal. So thinking about the impact of this work, what have you found it to be both for your patients and the community and hospital staff?
So I'm happy to start with that, and then I'll maybe pitch it to Chief Sneed and Casey to talk about the community. But like any health system, we track, different outcomes. What we've seen and what we believe is that by using this relationship-based model, we're able to get, top decile, results and a lot of preventative health things, like mammograms that are not the most pleasant thing in the world to do. And I think actually I'll pitch it to Casey because he has I think he has a good story about that in a second. So we are seeing good outcomes. There are a few things we're struggling with, but I think what we see is that when we have taken the time to build those relationships, we get better outcomes, and the patient experience is so much better. And that's extremely important for us here. Casey, do you want to share that anecdote that I know you love to share?
Sure. Thanks, Rick. So, Julia, a lot of times it's difficult for people to connect the dots. When we say that improving population health is a function of patient-family engagement, and that's a function of relationship-based care, it's really hard sometimes for people to connect the dots. And one of the stories that I like to share is the story about my own mother. My mother died in 2011. Unfortunately, she had diabetes and hypertension and eventually died from renal failure. But what a lot of people don't know about my mother is that she was a breast cancer survivor. She had survived breast cancer for more than a decade before she ultimately succumbed to kidney disease. And my mother was a breast cancer survivor because she had a mammogram. And she had a mammogram because she had a relationship with Dr. Bullock. My mother told me this story. She said that every year Dr. Bullock would remind her that she really was in the age group that she should have a mammogram. And my mother had no interest in that. She didn't understand the benefits of it, and all she understood was that it was described as a really unpleasant experience. And then ultimately one day, Dr. Bullock brought it up to my mother again, and my mother said, "Okay, Dr. Bullock, I'll do this for you." And Dr. Bullock said, "Well, don't do it for me, do it for yourself because you're worth it, you're important." But what Dr. Bullock wasn't recognizing, I don't think at the moment, is that she had built such an influential relationship with my mother, that my mother was willing to step out on faith and subject herself to something that she didn't believe in, that was very uncomfortable, but she was doing it because the relationship, the tohi, the relationship with Dr. Bullock was very important. And she had a mammogram, and she survived breast cancer because of early detection.
If I can jump in on that as well, I think one of the outcomes from the model of care that we are offering now is it creates a sense of personal responsibility for our own health as well. When the hospital was more institutionalized and more of the federal model, you went when you had to. And oftentimes it could have been when it was too late, right? Because it was not someplace that you wanted to go. But it just creates this sense of ownership, if you will, in our own health, that we're responsible for our own health. And we have a team of doctors and care providers that care about us. And so, and I love that story, Casey, because in a sense, it's like, well, I don't want to let my favorite doctor that I used to have, who's not here anymore, was Dr. Bub. And loved her as a doctor. And I would tell people all the time, I'd say, she is the best doctor I've ever had, because she just genuinely cared about me. Like I sensed that when I was around her. One of the things that I like to talk about that's so different about our hospital that we do is the annual memorial service that we do for those families who have lost a loved one throughout the course of the year. And I went the first time. I hadn't lost a loved one, but I was there just to be supportive and to Casey asked me to say a few words. And I was really pleasantly surprised at how many people showed up and to see how meaningful it was to the family members that our hospital and our doctors and our staff cared so much about their family members, and to see them openly sharing about how meaningful it was that, the care that they received while they were there, and the fact that, they were being remembered at this service. It's so different from any other healthcare system around.
These are both really wonderful stories. Thank you for sharing those. So I want to shift gears just a little towards our current COVID-19 pandemic. Your community has been widely recognized for successful you've been in your response. Casey and Chief Sneed, can you share that story and talk a bit about how you've managed to be so successful and so many other communities have struggled?
Sure, Julia. Actually, to unfold the story, I will pitch it to Chief Sneed to kick it off, because it was this wonderful partnership between the health system and the leadership of the tribe that kind of created an overarching community-wide framework. And then I'll fill in with some of the details regarding the kind of the clinical response or from the health system. So, Chief?
Sure. So when we first started getting reports of COVID and I guess for as early as January, my Secretary of Health and Human Services, Vicki Bradley, in one of our meetings said, hey, you've probably seen on the news about this Wuhan virus. We're monitoring it. We're watching. We're just we're taking a wait and see approach. And then, of course, modeling started coming out, and then all of a sudden everybody was on high alert. We responded very quickly, and this goes back to the sovereignty issue. So we have the ability here, and I tell people all the time when I do talks on leadership and sovereignty and rights and so forth, that sovereignty and rights are just ideas and principles until you act on them. You have to act on them to give life and vitality to them. Otherwise, it's just an idea. But when there is a public emergency or a situation that occurs, we have the ability, because we are sovereign, to take immediate action. It's very unique. It's so different from like our county governments that are around us. Essentially, they can do what the state allows them to do through the state statute process. We have the ability to make laws and set in place things very quickly and enact them. So when the data started coming in, I remember very distinctly the day we had the conversation. We were at the Emergency Operations Center, and we were just doing a briefing with the leadership team. And then afterwards, Casey said, hey, can I talk to you? And he and the Secretary of Health and Human Services pulled me into a side room, and they said, look, we just got these new models in, and here's what it looks like. And I remember the numbers. It was like, at that time, we had already shut down tribal operations, and we had already closed the casino. But our borders were open, and we were still pretty much business as usual. I said, if we continue to do nothing or just limited intervention mitigation at this point, the modeling is showing that by the third week of April, we will have 400 positives. We'll have 42, I believe it's 42 or 45 persons that will need to be hospitalized. We'll have 20 some persons that will need to be on ventilators, 18 or 20 that need to be on ventilators. And we only have, 32 ventilators from Haywood County West. So for 6 counties, we have 32 ventilators. He said, we have this opportunity to work with Dogwood Health Trust. We can follow the kind of the South Korea, Taiwan model, do mass testing. The best way for us to get a handle on this is to do mass testing so that we can identify those persons who are positive. We can isolate, quarantine, and stop the spread. We'll flatten the curve. And I said, great, let's do it. And beyond that, I'm closing the borders down. We shut off all access to the reservation except for tribal members, their immediate family, and for those employees who work on boundary but are not enrolled, they had access to come to and to go to and from work. We had our police and emergency services workers at every entrance to the border. We did that for 7 weeks and kept everything shut down. There was a real sense of community at that point, which to me, again, just demonstrates how being tribal and everybody being connected, there was just a real sense of community like I hadn't seen in a very long time here. Being tribal has its upsides and it has its downsides. There's a real sense of community. When there's trouble, when there's hardship, we always pull together very quickly, and that's the great part. The downside, is that, sometimes it's like with your family, you'll save your worst for the people closest to you. So it was really refreshing to just see the community pull together, and, the numbers bear it out. We've had great success with our mass testing. We've had great response from the community. We've had a lot of cooperative work between the hospital and public health and human services, which I think is something too that we kind of take for granted here at the tribe, that, well, yeah, of course, this is how it is. But that's not how it is in the rest of the country, and certainly not how it is in the rest of the world, where you have this cooperative relationship between a healthcare system and the public health division of a government, and also the executive branch and legislative branch of a government, everybody working in concert for a common goal. And I think that's why we've been successful.
I'd like to echo that. If anything, I think COVID-19 has strengthened what was already a unique partnership between public health and human services and the health system. I talked to chief medical officers across Western North Carolina, and nobody has this kind of close collaboration that we have been able to build here. For instance, our integrated care teams will take care of the medical needs of the COVID patients, while the public health professionals will monitor their isolation and quarantine and make sure that they have all the food and whatever they need to be safe, and they can stay isolated and protect the rest of the community. So it's been an acceleration, if you will, of an already strong partnership. We have actually gotten stronger because of this crisis, I think.
If I could just add a little bit more to what the chief was kind of saying. The great thing was we had tribal leadership that was willing to listen to the science and follow the data and follow the recommendations of the medical experts, and they did it without reservation. Chief Sneed called for an emergency meeting of tribal council. We met within, I think, 48 hours. And just immediately, the legislative branch of the government, the executive branch came together, said, yep, we're all going to do this. And we were full steam ahead. So then the next thing that we had to do is turn our attention to building the public health response system that didn't exist. Because unfortunately, this country, we've basically dismantled our public health infrastructure over the decades. And, like I said, we're a pretty large employer for a small community. So basically, we shut down our programs. We shut down things that were elective and that were not necessary. And then we completely redeployed those people. We redeployed physical therapists and nurse practitioners and nurses and registered dietitians. And we stood up a mass testing unit, and we stood up a contact tracing unit, and we stood up surveillance kind of capabilities, and basically just reinvented ourselves. And we stood all this up, and basically then started working with the public health system to say, okay, we're going to stand this up. And then once we get all these systems and processes in place, we're going to be your partner and hand it off to you when you've built up the public health infrastructure to take it over and manage it into perpetuity. That way we can go back to doing primary care and physical therapy and radiology and all the other things. So it was just an amazing partnership and a fantastic response.
And your rates have stayed pretty low throughout. Is that correct?
Yeah, I'll pitch it to Dr. Bunio to kind of give you the highlights around the data.
Our rates have stayed pretty low. We did have a little bit of a spike, like everybody else. At most, I think we had about 30 cases. Right now, our test positivity rate is about 1.4%, which is lower than anywhere else in Western North Carolina and many other parts of the country. So we are cautiously optimistic at this point. We're not out of the woods yet, but
sounds like you're on a good path. So to bring it back to that relationship-based care model that we talked about before, how do you feel like that has supported your COVID-19 efforts and response?
One of the key components of the relationship model is the trust that we can build between our providers, our health system, and the community. And so this, I think, was really critical for us. The entire country is facing a lot of confusing information. Who are you going to trust? The CDC says this one day, and other leadership says something else. So I think we were able to leverage that trust to be influential with this community with our communication strategy, which again was a partnership with public health. And we were able to do, live streams and posters and billboards, and had the pleasure of sitting with the chief on one. And we had a consistent message that the community trusted. And I think that's been a big key to our success here.
If I can add to that, it was, and this is something we struggle with all the time in tribal communities, is a lack of trust. Right? There historically has been so many wrongs done. One thing I despise is kind of victim mentality. I always look to the strength of our people and try to accentuate that and highlight that. But the fact of the matter is there have been so many things done over the history of tribal nations that have caused deep-rooted mistrust of institutions, deep-rooted mistrust of government, both federal and tribal, even our own, mistrust of even our own tribal government. And I think the key to our success here has been the very open communication and open dialogue where Dr. Bunio and I and Casey and I and my Secretary of Health and Human Services and I, we all spent time in these roundtable discussions, essentially PSA, it was kind of a talk show. Dr. Bunio would field questions, one-on-one with the host, or we would have a roundtable discussion about issues. And this is where we were using social media to kind of take the pulse of what are the things that the community is concerned about. And let's address those, because in the absence of good information, it's always backfilled with misinformation that makes the problem worse. So I think it was a really good demonstration of utilizing social media in a positive way, because it can be very toxic and abused and everything else. Somebody asked me, I recently did a television interview, or rather a news interview for over in Knoxville, and they said, you guys have been so successful. How have you continued to just lead and for you guys to be successful in all of this? I said, you have to just stay focused on the mission and just ignore the noise. The noise is always going to be there. And with social media now, I'm like, everybody has a megaphone and a platform, but you can take that information, parse through, and find nuggets of truth in there that things people are concerned about, and speak to that without actually giving any energy to this negative voice over here. You just kind of ignore them and speak to everybody else with the truth. And I think we've been very successful in doing that. And then what I would witness happening on social media is when people would chime in with things that just weren't true, other people would say, well, no, you need to go watch that video. Go watch that video with Dr. Bunio, or go watch that video with Chief Sneed. They talked about this already. That's not true. So I think that was an excellent strategy that didn't give any of our energy to the negativity, but instead we stayed focused on the mission at hand and getting the critical information to our people.
That's great, and transitions us nicely to where we start to wrap up. So I'm really interested in what you all have learned over the course of this work, both in implementing the relationship-based care models and responding to COVID-19. What are your takeaways?
The takeaway is protecting the health of the population is a responsibility that's shared by the entire population, right? Again, it doesn't matter, in my opinion, it doesn't matter if we're talking about chronic disease or if we're talking about communicable disease control, right? It still requires the trust and the engagement of the populace. And so the local health systems have to have the trust of their people, and their people have to believe genuinely that the local health system really cares about their best interest, so that they don't second guess or question. And so when you need compliance, and I hate to use that word, but sometimes it's a dire situation and you need compliance. Like, for example, you may need 200 people to come in and have a nasopharyngeal swab today. Well, if you have to ask that of your community, you have to have a very healthy trust account with your community to begin with. I think too many times healthcare systems, they have conflicting priorities. Some healthcare systems are constantly fighting for market share and for profit margins and other things to exist and survive. And we're very fortunate here that we can stay very true to our core purpose, again, to ensure the prosperity of the next 7 generations in pursuit of our vision, which is to be significant in the lives of the people that we serve.
Yeah, I think what I've learned and observed over the course of this, the COVID-19 crisis, is that the people that we've been able to attract and employ here have really stepped up, and they've stepped up to protect this community. It really is impressive how people have gone out of their comfort zones. Nobody said, hey, I didn't sign up for this. They stepped up. They knew that they had a relationship with this community, and they were determined to do what it took. And it was very impressive to see people rise to the top and meet the crisis.
So to echo a couple things, Casey mentioned, trust, and again, that seems to be kind of the overarching theme through all of this. And that really is the basis of relationship, right, is trust. And so you see how what was put in place as far back as 2003, recognizing that, we have to have relationships with our patients, with our people, and that sowed the seeds of trust, and how when the crisis hit, it was a fairly easy transition into our response. But I think equally as important, the fact that we have leaders here, right, at the hospital, in tribal government, the team that I have around me, you have to have people who, number one, understand the mission, right, who are focused on the mission, and equally as important, who genuinely care about people. Because if you have people who are mission oriented but don't care about people, or don't have the EQ, if you will, to deal with people, the mission will fail. Or if you have people who genuinely care about people but don't understand the mission will fail. So I think what this demonstrated, and what I learned from this, is that, number one, I can trust the people around me. When people say to me, "Oh my gosh, you've done such an amazing job," the first thing I say is, okay, first of all, it's not me. I want you to know we've had to make some hard decisions, and they weren't just my decisions. That there were times, when Casey said he thought it was like 48 hours, it was 24 hours from the time that we made that decision to where I called a special counsel on a Saturday, and counsel came in and we said, "Guys, this is what we need to do." And everybody came together and we did it. It demonstrated that in crisis, there was a level of trust, but I don't think that happened then. I think that the seeds for that were sown much earlier, and we just saw the fruit of it in the midst of this crisis.
So what's next for all of you?
I'm going to retire. Well, honestly, I mean, for the tribal government, it's now the challenge now is to all of the kind of the warm fuzzies and the things, the nice things we experienced of all coming together and working together. Now that we're back to kind of business as usual in operations, and certainly it's not. Everybody's wearing masks now. There's social distancing happening. There's sanitizing happening all over the place. But when I say business as usual, I mean there's a way that things operate in any government, right? So one of the things that's changed for me personally is I have become very deliberate about when I see these dysfunctional behaviors and maladaptive coping mechanisms in relationships amongst my peers, where I used to get angry about it and not address it. I would just be irritated about it and kind of carry that with me. I'm like, no, wait, you know what? We need to talk. And I said, do you honestly think that, this person, do you really think that about them? I mean, come on, and so for me, it gives me hope that, because I saw that trust and cooperation manifest, that gives me hope that we can nurture that and foster it and help it to grow. So that's what's next for me. I got 3 years left in this. After that, I don't know. But for the next 3 years, that's going to be my focus, is to try to, those characteristics of well-being and healthy relationships and so forth that, Casey and his team are nurturing and fostering at the hospital, to help bring that tribal-wide.
I think one of the things for me, what's next, is to really build on our relationship and partnership with public health. Hopefully see that we can build up that infrastructure. As Casey mentioned, it's something that across the nation has not been given the kind of support that it has needed. And we see now what happens, when we don't do that. So I'm looking forward to, I think I have 7 years, unless Casey changes his mind and wants me to move on somewhere. Over the next 7 years, I'd like to see us continue to build up our public health, our population health focus, create the healthiest community that we possibly can. And I think that's where, as things go back to normal, whatever normal is going to be, well, our normal was trying to address population health, but now we've got a real strong partner. And I think that's why we're going to be successful.
Wonderful. Casey, last words?
Yeah, so the what's next, hopefully, as Rick said, we'll continue to be a partner with public health. We'll get the infrastructure in place to help us just monitor and maintain things. Hopefully a vaccine will come out and we'll put this pandemic behind us, and then we'll turn our attention back to what our original focus is, and that is improving the health of the population by building healthy, influential relationships and building a community that is resilient to the intergenerational effects of stress and trauma and the adverse effects of stress physiology. We are absolutely determined in this health system that we are going to wipe out the horrible things that cause extraordinary stress physiology in our children. We are determined we are going to put an end to abuse and neglect and sexual violence and all of those horrible things that cause the epigenetic effects that then lead to all of these comorbidities. And we are going to be unrelenting in addressing that and building a healthier community.
We look forward to seeing how that work continues to grow. And I really think that the thread, as you all have mentioned, that has tied all of this together is really the importance of trust and relationships and really caring for the people in our communities. So Casey, Dr. Bunio, Chief Sneed, thank you so much for joining me today. This has really been an excellent conversation that I'm excited to share with our members in the world. For more podcasts and resources to help you promote value in your community, I encourage you to visit the Value Initiative's website at www.aha.org/thevalueinitiative. And that is it for today. Thank you so much for listening and joining us.